Hello, I'm Eric Strong from Strong Medicine, and today I'll be continuing this series on medical presentations and written notes. I've already covered the medical H&P, including 2 example presentations. This video will describe the content and format of the so-called SOAP note and SOAP presentation. Notably, although SOAP is a different and shorter format than the H&P, many of the same general principles apply. So if you're unfamiliar with H&Ps, you may want to start there first and come back to this afterwards. Now, what is the purpose of the SOAP note and presentation? In extreme brief, the SOAP is a daily update provided for a hospitalized patient. It communicates to other members of the broader healthcare team what's changed about the patient in the preceding 24 hours and how your plan has changed on account of that. The SOAP format is used primarily by the so-called primary teams in the hospital, that is, the one team who coordinates care for a given patient. However, some consulting teams will also employ a SOAP-like format for their documentation and bedside presentations as well. While it may not be apparent in most hospitals or on most inpatient services, SOAP is only one possible format of the daily update, albeit by far the most common one. The more general term for the written form of the daily update is a progress note. So in short, all SOAP notes are progress notes, but not all progress notes are SOAP notes. Alternatives to SOAP include the system-based notes and presentations common in ICUs, which are similar to SOAP except the plan is organized by organ system rather than by individual problem. Whether or not that format is actually better in the ICU environment is debatable. There's also a more recently described alternative to SOAP called the EAP note and presentation. In my opinion, EAP is the best format for physician and APP teams, despite it being the least commonly used. I'll be discussing it in an upcoming video in this series. And last, there's something called the APSO or APSO note, which is just a variation on SOAP in which the order of the S and O and the A and P are switched, but everything else is otherwise unchanged. The rest of this video will focus solely on SOAP notes and SOAP presentations. SOAP is an acronym for the main components of the note and presentation. The S is for subjective, which is what the patient is experiencing. The O is for objective, which is what you as the clinician have observed. The A is for assessment, what you think is going on, and the P is for plan, what you're planning to do about it. As with the H&P, the assessment and plan are often bundled together. Unfortunately, while it's a little catchy, the SOAP acronym leaves out 3 components of the format. The first is the ID line, often known colloquially as the one-liner, which serves to reintroduce the listener or reader to who the patient is. The second is the overnight events, and the third, included in the note but not in the oral presentation, is the full list of active inpatient medications. This med list is imported automatically by the EMR, is rarely if ever edited, and I won't be discussing it further. But I will go through each of the other 6 sections one at a time. First up is the ID line. This is one frequently run-on sentence or run-on sentence fragment that summarizes the patient's condition, diagnosis if known, and or reason for continued hospitalization. It should be brief and to the point. The ID line of the SOAP is roughly analogous to the chief complaint of an H&P. Importantly, as the patient's condition evolves over time, the ID line should be routinely updated with new information. However, the ID line is also often imported into the note template by the EMR, as the ID line has been entered into the chart in another location. So routinely updating it takes an extra cognitive step. Let's take a look at some examples of good ID lines. A 61-year-old woman with COPD and HFrEF, or heart failure with reduced ejection fraction, initially presented with severe community-acquired pneumonia and COPD exacerbation requiring 1 week of mechanical ventilation, extubated 2 days ago, now slowly recovering. A 46-year-old man with a recent diagnosis of stage 1 colon adenocarcinoma, Now post-op day 3, status post a right hemicolectomy, complicated by injury to the right ureter. An 88-year-old man with advanced dementia, oriented only to self at baseline, admitted with acute ischemic left MCA stroke, complicated by aphasia and hemiparesis, made comfort care yesterday and now awaiting SNF placement for inpatient hospice. And last, a 31-year-old woman with alcohol dependence and a history of withdrawal seizures, admitted for monitoring during acute detox, now 24 hours status post her last drink, and doing well on standard CWAP protocol. I'll now move on to overnight events. These consist of anything since the last update, either via presentation or note, which required a clinically relevant and unexpected change in plan. The reason that overnight is in quotation marks is because these events don't necessarily happen overnight. For example, if you last rounded with your team at 10 a.m. on Monday, and the patient then had a rapid response team call for acute respiratory distress at 2 p.m. that afternoon, if the team next formally rounds with the attending physician at 10 a.m. on a Tuesday, that rapid response call, despite being 20 hours ago, should still be included in overnight events. Some examples of what might constitute an event that belongs here: a significant change to the patient's vitals, the new onset of altered mental status, such as delirium, a significant fall, which I would arbitrarily consider to be one that warranted a bedside evaluation by the covering clinician, surgery, even if it was expected, belongs under the events, as well as an unexpected bedside procedure, such as a thoracentesis or lumbar puncture, or any procedural complication. Last, any new indication for non-invasive positive pressure ventilation, antibiotics, IV fluid, or blood transfusion. There is one more thing to discuss with the overnight events, specifically when documenting them in the written note. It has become common practice at some institutions, including my own, for the overnight events section to not just be limited to the preceding 24 hours, but to instead become a running list of all events that have happened since admission, including major changes in the status of the patient, which may not have been explicitly included in the overnight events for an individual relevant day. So for each daily progress note, the writer copies and pastes the list of events from the previous day's note, and then just adds whatever has happened since. While this practice significantly adds to the overall length of the note, which is generally a bad thing, it does make it easier to understand the sequence of events in a patient's hospitalization when either you are joining the patient's team far along into that hospitalization, or when you are tasked with writing a discharge summary for the hospitalization that may extend back weeks or even months before you personally first met the patient yourself. So while some faculty frown on this practice, I think it's perfectly fine and arguably even preferable. Now we are at the subjective section. This is where the clinician describes how the patient is feeling. Any new symptom should be identified and described, and any symptom present the previous day should be addressed with an update. For example, if the patient was experiencing shortness of breath yesterday, is it still present today? And if so, has it changed in any way? Even if not a symptom per se, some clinicians will comment here on appetite, meal intake, bowel movements, the ability to pass gas for post-operative patients, and even how much the patient has walked around on their own. Although the subjective section of the SOAP seems a little like the HPI of an HMP, it should be much briefer, unless there has been a dramatic change in what the patient is experiencing. The objective section of the SOAP has two subcomponents, the first of which is the physical exam. This should be very similar to the physical exam section of an H&P. Report observations objectively using proper medical terminology. In the written note, every observation and maneuver that was performed should be included. In the oral presentation, you should focus on only those findings that are most centrally relevant to the patient's diagnosis or condition. For both, report vital sign ranges and the ins and outs for the preceding 24 hours, except for the temperature, Temperature is usually reported as the Tmax, or maximum temperature in the last 24 hours, and the T-current, or the most recent temperature reading. Only in patients with clinically relevant hypothermia should you ever mention the minimum temperature. Last, and most importantly for the exam, the physical exam in both the note and the presentation must be tailored to the individual patient. One of the most consistent errors that trainees and senior clinicians alike make is performing a nearly identical exam on every hospitalized patient every day. At best, this is a waste of time, and at worst, it leads to missed findings that aren't even checked. I covered this a little bit in the H&P video when I showed this documented exam and discussed how findings can be identified as those providing insight into the patient's overall condition, those that are relevant to the primary diagnosis, those that look for complications of the primary diagnosis, and those that evaluate the status of the patient's pre-existing chronic conditions. You should do something similar for the daily updates in hospitalized patients, though as a general rule, that exam can be briefer. For one thing, most chronic conditions are unlikely to change significantly from one day to the next, but you do want to consider what daily maneuvers and findings are indicated because of that specific patient's acute diagnosis. A few examples of what I mean. For a patient with acute decompensated heart failure or acute coronary syndrome, exam maneuvers that are often neglected include looking at the JVP or IVC on point-of-care ultrasound to estimate right heart pressures, and the subjective assessment of extremity temperature and capillary refill as very rough surrogates for perfusion and vascular resistance. For a patient presenting with a complication of decompensated cirrhosis, always check for asterixis each day, which is a sign of worsening hepatic encephalopathy. In patients with bacteremia and sepsis, a quick skin exam to look for petechiae and ecchymoses that could be a sign of a dysfunction of platelets or the coagulation cascade, which can complicate sepsis. For patients with an acute stroke, please do a daily neural exam that is more than just the pupillary reflexes and extraocular muscle testing. This is presumably not an issue on neurology services, but for some reason, internists and internal medicine residents don't do good follow-up neural exams on stroke patients. One caveat is that sensory testing is usually skipped in the daily exam unless the patient is voicing sensory symptoms. And the last example, for patients with severe pancreatitis, be sure to do a skin exam of the abdomen and flanks, as this could reveal bruising consistent with pancreatic hemorrhage. This is just a tiny subset of daily exam findings that may not be indicated for all patients, but are definitely indicated for some. Having gone over that, there are some exam maneuvers to check in all inpatients every day, though this specific list is debatable. I know plenty of clinicians who advocate for more than this, and a smaller number who advocate for less. But in my opinion, this list includes the vitals, I's and O's, even if there's just a qualitative record only, like 3 trips to the bathroom and 50% of their meals. Mental status, which doesn't mean a formal MOCA, mini-cog, or mini-mental status exam every day. If the patient's level of consciousness, speech, language, and thought process are all normal based on your routine conversation with them, that's sufficient for the daily exam. But if any of that seems off, or if it was off the day before, a little bit more thorough testing is warranted, such as tests of orientation, attention, and memory. Lung auscultation, primarily to listen for crackles that could indicate the development of pneumonia, silent but clinically relevant aspiration, or volume overload. And assessment for DVTs in the legs. Additional maneuvers that some clinicians recommend for all patients include cardiac auscultation and palpation of the abdomen. And among clinicians who advocate for an even shorter exam, usually lung auscultation is what they would cut out, stating that any pulmonary finding of relevance would necessarily be preceded by the patient reporting a respiratory symptom that would prompt the exam in those cases anyway, which I think is a reasonable point. The second part of the objective section is for diagnostics or tests. For an oral presentation, only highlight new results that are relevant to today's assessment and plan. Please do not read off all 25 new blood test results every morning for every patient. However, if a patient is appropriately on telemetry, meaning they have a good indication for continuous ECG monitoring, that data is always relevant enough to summarize for the presentation, even if that summary is as brief as, on telemetry, the patient remained in sinus rhythm 100% of the time. For written SOAP notes, include all new results, most of which will be automatically imported into the EMR template. For radiology and pathology tests, for both presentations and notes, summarize the report rather than either reciting them verbatim or copying and pasting the entire report into a note. While there are times in which copying and pasting an entire radiology or pathology report into the discharge summary is appropriate, it is never needed in a daily progress note. After the O comes the A for assessment. As mentioned, this is a summary of what you think is going on with the patient overall. It's relatively similar to the assessment of the H&P, except with less emphasis on the initial presentation, particularly if a diagnosis has been established. The assessment should contain analysis and interpretation of new data, unless the patient is completely stable and unchanged from the previous day. An assessment can be as short as a single sentence or as long as several paragraphs, depending on circumstances. And last is the plan, although the P could also stand for problem list, since that is the form in which the plan is provided. The SOAP's problem list follows the same general principles as the problem list from the initial H&P, but for a SOAP oral presentation, only include those problems that are relevant to the current hospitalization, unless it's the day of discharge, in which case you should list all of them. Be sure to revise the problem list each day. This means add new problems, remove problems that are completely and totally resolved, and reorder problems as their urgency and priority change. Although I spent much longer on the preceding 4 components, the assessment and plan are the most important parts of the note and presentation. Even if they are relatively brief in absolute terms, and that is how many words they take up, this is where you should spend the majority of your cognitive effort. I'll end with some common pitfalls with SOAP presentations and notes. The ID line is not updated. Overnight events are missing, which usually happens because the events were in the preceding afternoon and aren't thought of as, quote, overnight. The subjective section is too verbose. The physical exam has been not appropriately focused on findings that are clinically relevant to the patient's specific diagnosis. For oral presentations only, either every lab is recited or centrally relevant labs are omitted. Labs being presented before the exam, which for some reason is really common. The problem list is not updated. And last, for both notes and presentations, they are just too long overall. That's it for this video on SOAP notes and presentations. The next videos in this series will consist of 2 example SOAP presentations, followed by a video explaining the EAP format of presentation and progress note.